This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs. Also, make sure to check out and subscribe to our YouTube original channel, UCTV Prime, available only on YouTube.
So I'm going to introduce our next speaker, Dr. Andrew Parcell. Dr. Parcell is Associate Professor of Surgery and also heads the pancreatic islet cell transplant program at UCSF. And Andy is co-director of the Bariatric Surgery program at UCSF, and we are now in this fatty liver epidemic, and we're really fortunate to have the surgical expertise to be included in part of the management algorithm for these patients. So I'm excited to hear about your talk about your experience with bariatric surgery in patients with cirrhosis due to fatty liver disease. Thank you for coming for this talk. And this is yours? Okay, great. Thanks.
Mm-hmm. Hi, everybody. Thanks for coming. I'm really tachycardic from that last debate. Listening to you guys go at it. I'm like, wow. Anyway, I know we're running behind. I'll try to make this brief. I have to preface this talk by telling you that I don't have a lot of data aside from our center because not many people do this type of procedure in patients with cirrhosis, but we've been accumulating numbers, and I think our results are quite good, and I think this option for obese patients who need a liver transplant is a viable one. So as you all know, and I'm sure you've all seen this before, the trends in obesity are increasing throughout the United States as well as the rest of the world. Currently, there's areas of the country where there's more than 30% of patients who are obese, meaning BMIs of greater than 30, and in some ethnic subpopulations that reaches almost 100%. So it's becoming a very big problem. And that problem is reflected in the transplant populations that we see throughout the country. This is data from UCSF from 2007, so the numbers are actually higher. Ignore the kidney side, but you can see in liver transplant patients or who are awaiting transplant, about 30% or a third are obese, and about 15% are morbidly obese. And what does that mean? Does it affect outcomes? There's been a lot of debate about this, but I think data is emerging that it is a problem, especially with liver transplant patients. We see more postoperative wound infections, pulmonary problems. For an unclear reason, there is more primary non-function. And obviously the patients stay longer as a result of these complications, and the costs are significantly higher. And there's also data emerging that shows that actual outcome, so patient survival after liver transplant correlates with BMI. And even if you correct that for MELD score, which is what was done here in this study, you can see that patients who have a BMI of more than 40 and a MELD of more than 22 have a much worse survival than patients who have a normal BMI and the same MELD score. So it does affect survival. So now what do we do about that, or what have we been doing about this at UCSF till about 2 or 3 years ago? Well, we've had criteria because we're aware of this data, and we feel that patients with BMIs over 50 we think are that's an absolute contraindication to transplant because of the complications. BMIs of 40 sort of surgeon's choice. We often attribute high BMIs to some volume overload and so forth, but we do have rules for that. But we really didn't have a structured program as to how to help these patients. We'd refer them to weight loss clinics. We'd talk to their primary care physicians and so forth. And obviously the results were not very great. We really saw only about a 10% or less adherence to these dietary programs and actually losing enough weight to qualify for transplant. And that's not surprising when you look at the national data looking at diets and even medical dietary regimens or medication regimens. You can see that looking at randomized controlled trials for dietary therapy, average weight loss is very poor, about 8 to 10%, and patients who have a BMI over 50, that's not really going to be sufficient. And a lot of patients gain the weight back. And even pharmacotherapy, which was touted as sort of the new or potentially more efficacious approach to weight loss, has really not achieved what we expected. And even drugs such as fen-phen really just reached about 10% weight loss on the average. So none of these things are really, I think, sufficiently powerful enough to achieve the weight loss that we need. And as you all know, bariatric surgery has now become the most accepted procedure for weight loss in morbidly obese patients. These are the criteria. I'm sure you're all familiar with them. BMIs of greater than 40 or greater than 35 with significant comorbidities related to obesity. They need to have tried and lost and not achieved any weight loss in a medical program. And the efficacy is excellent. It's about 60 to 70% of excess body weight loss. So on the average, about 100 pounds per patient. Whereas, the medical regimens achieve very much less. And a lot of that is due to the fact that these patients are not hungry. They eat, they get satiety, and they don't wait until the next meal to eat more. They feel fine with much smaller quantities of food. And I think that's really the main sort of long-term thing that makes them maintain the weight loss. So currently there are 15 million patients or adults in the US that meet the criteria of morbid obesity. We do 130,000 bariatric procedures a year. That's the number one general surgery procedure currently, or a laparoscopic general surgery procedure. And you can see that it's a huge number of patients that still need this. There are different types, and again, I'm sure you've seen these before. Just briefly going over them, the most common one is the Roux-en-Y gastric bypass, which is this. Best studied for the longest amount of time, best outcomes, and the least sort of amount of variability between patients. The band was quite popular a while ago, primarily due to, I think, the companies that were making the band as a less invasive approach to weight loss. Again, not as effective. A lot of sort of interpatient variability because the patient is the one who says whether they feel full or not, and the adjustment in the band is dependent on that. And it's really not as reversible as you think because this band is actually plicated or sewn into around the stomach sewn around it so it doesn't slip, and it's quite difficult to remove that. And then there's the sleeve, which I'll talk about later, which is a newer procedure which basically removes much of the larger curvature of the stomach and leaves a narrow tube. These malabsorptive procedures are done by some physicians, particularly the duodenal switch, but I think on the whole the bariatric community is not that excited about doing these anymore because they do cause a lot of problems. Weight loss is great, but it's really hard to judge the weight loss against potential nutrient malabsorption. And in a patient with liver disease, these would obviously not be an appropriate choice. When you look at weight loss in these procedures, control patients or patients on a diet, you can see that the bypass is quite effective and weight loss is maintained at about 30% less weight over 15 years. This is the gastroplasty, which is about what the sleeve is. Maybe a sleeve's a little more effective. And this is a band, which is less effective. And importantly, the comorbidities associated with obesity are dramatically reduced. You can see that with the bypass, which is the green lines, you can see there's a 80 to 90% resolution of diabetes, as well as hyperlipidemia, hypertension, and sleep apnea. The band is not quite as effective in some of these. And I think some of that has to do with the neurohormonal regulation of insulin sensitivity and so forth that you see with gastric bypass. So people have looked at doing these bariatric procedures in transplant patients. The first person was actually Dr. Alexander, who looked at gastric bypass outcomes in patients who needed a kidney transplant. And he found overall, and I won't go over the data very closely, but he found that they did quite well. They were able to lose sufficient weight. They maintained weight, and many of them went on to transplant. And these were all open gastric bypasses done about 8 years ago. So we went on and looked at this same sort of situation doing laparoscopic gastric bypass or sleeve. And again, we found that patients with renal failure tolerated this quite well. And we, in fact, did some patients with cirrhosis and some patients with end-stage lung disease and found that they actually tolerated these procedures well, lost the weight, and many went on to transplant. Their lengths of stay were not any different. Complication rates weren't any different. And I think this was sort of the kernel for studying this under more directly and with more patients. So what is the best procedure for a patient with cirrhosis? The lap gastric bypass, as I mentioned, is a great one for weight loss, but it is technically complex, and I think in these patients, if you do need to study the biliary system down the line, or if there's some potential problems with variceal bleeding, there's no way to reach that endoscopically. You can, but it's quite difficult. So I think that's one disadvantage. I think there is more potential for nutritional deficiencies, and again, in these malnourished patients or in these low albumin, potentially malnourished patients, it's a problem. The band we talked about, again, I'm not a big fan. It's not as effective. You need a lot of follow-up afterwards. You have a port in your abdomen that needs to be insufflated intermittently to make sure that it's got enough fluid in it. And again, I think that it's with a foreign body and so forth. And as it turns out, the port would be placed right where the incision goes for the transplant. So you'd have to redo all that. It's not really, you can't really put it anywhere else. And then finally, the duodenal switch, which is the malabsorptive procedure, again, not a good option for a variety of reasons. So the sleeve gastrectomy is a relatively new procedure. It's just recently been approved by some insurance companies. CMS is talking about whether this should be approved as a standalone procedure. It was started originally as a sort of adjunct procedure for massively obese patients, so patients with BMIs of 80 or more, where you would do the sleeve first, have them lose some weight, and then you would do a duodenal switch afterwards, and that would allow them to lose more weight. And the second procedure was a little easier. But people found that a lot of patients lost a lot of weight with just this. So this has been sort of refined. The size of the tube that's left has been measured and determined what's appropriate and so forth. And I think it's a very effective procedure. It's quite easy technically, since you don't have any bowel anastomoses and you need a limited view of the internal of the abdomen. It's done quite quickly. It doesn't have a lot of effects on nutrient absorption, really. It allows endoscopic access, so important in cirrhotics. And there is some evidence that it has effects on gut hormones, just as gastric bypass does. So ghrelins, incretins, all those GLP-1, GIP are affected because they are secreted by this part of the stomach. So removing that actually has a beneficial effect on satiety and insulin resistance, which you don't see with the band. The downsides are that maybe less weight loss, although now long-term data is coming out and it looks like the weight loss is quite good with these procedures. Patients with reflux are at a disadvantage. This is a high-pressure system in contrast to a gastric bypass because the pylorus is intact. So if someone has a lot of reflux, it can get a lot worse. So you need to make sure that they're evaluated for that and they get appropriate therapy. And then the complications are a problem. So because it is a high-pressure system, if a staple line breaks down and there's a leak, it's really difficult to heal. And you can end up having these patients with drains and feeding tubes for months before anything heals, or even have to put in covered stents to try to cover that up. In a gastric bypass, it's a low-pressure system, and the pouch, the leak, will just heal by itself if it's appropriately drained. Now, when you look at these two pictures, they look very similar. This is I can't even tell anymore. I think this is the sleeve. So you can see there's a little extra fundus up top. And then that's the sleeve and the antrum, which we don't really narrow. And then this is a gastric bypass. So you can see how these two achieve comparable weight loss. The anatomy is really very similar in terms of volumes. This is a paper that just came out recently in the New England Journal that looked at sleeves, a different type of population, but it really showed again, how effective the sleeve is. Compare the sleeve with laparoscopic gastric bypass or medical therapy in terms of change in BMI at 1 year. And you can see the sleeve and the gastric bypass are very similar. And then looking at hemoglobin A1C or treatment or control of diabetes, you can see that the sleeve and the gastric bypass were also quite similar. So this was very encouraging data. All patients who had these procedures had a reduction in their antihypertensive meds and lipid-lowering agents, and they seem to be this was occurring at similar rates. So we adopted that procedure for our cirrhotics for the reasons that I mentioned previously. Here are our selection criteria, essentially the same as they would be for bariatric surgery in a regular patient in terms of BMI, so 40 or 35. Child's A or B, their ascites needs to be well controlled, and they need to have relatively small varices or have them decompressed. And importantly, their transplant workup doesn't necessarily have to be completed, but has to be in progress so that if they do decompensate during the procedure, there is some backup in terms of a liver transplant. We've done probably about 30 now. I have 20 up here. You can see these are the demographics of these patients. BMIs were quite high, about 46. Their MELD scores were low because the initial patients that we did, we tried to have as healthy as possible. We've become a little more bold, I guess. And you can see the weight loss is quite dramatic. Their BMIs dropped to about 33 from 46 at 1 year, which is about a 45 to 50% excess weight loss. Hospital stay was about the same as we see in our non-cirrhotic patients, and EBL was not any different. We did have some long-term mortality in 2 patients, and this is due to exacerbations of their underlying liver disease, so not from the surgery. And of those, all achieved candidacy at about 6 months after the procedure, and 7 of those so far, maybe more now, have undergone transplant. This is just a graph showing the weight loss, how it's quite proportional over the first year. And when we look at the reduction in BMI in our series versus the regular series with sleeves, you can see that it's about the same. So it's not like they're losing less weight or more weight or whatever. It's about in par with what you would expect. And the patients really actually feel quite well. I haven't seen any patients who really have suffered dramatically because they haven't been able to eat as much. Their comorbidities resolve as you would expect. About 60% of our patients had resolution of their diabetes, about 10% had partial resolution. Their blood pressure meds all dropped. They had stable vitamin levels, and then their nutritional parameters, MELD, and so creatinine and so forth, all remained quite stable. So it wasn't really, I don't think it was a big shock to the system to undergo this. We did have problems. We had complications in 5 patients, wound infections. This sort of harks back to an issue with the sleeve in terms of being a high-pressure system. We had one patient who had a leak in the upper part of the staple line due to a retained NG tube. So we always asked the anesthesiologist to remove the NG tube. They didn't do it fully, and the stapler went right through it. We recognized it, tried to repair it, but because it is a high-pressure system, it really never repaired. He was also quite sick from his liver disease, and really it was a 4-year struggle of just stents and drains and so forth before he finally passed away. So we do have obviously a protocol in place now that makes sure that all that is taken out and everybody's aware of it. We had some exacerbation of underlying liver disease and kidney disease, and as I mentioned, the other 2 patients died a while later after worsening liver failure. So the 7 that have undergone transplant, the demographics are shown here. About 6 to 50 months to transplant. Liver and liver kidney were the organs that were transplanted. You can see the BMI at transplant was about 31, down from a 46. This graph shows the 7 patients and their weights before and after transplant. So before bariatric surgery is the black, before transplant is the red, and then after transplant at 6-month intervals is the yellow. And you can see some of these are not that far out, but the weight has been relatively stable after transplant and has been maintained there since their bariatric surgery. We have done some patients, we have done some liver transplant recipients who have gained weight and have developed, recurrent NASH, and have done sleeve gastrectomies in these patients, and results are relatively good, although I must say this population is a lot more complicated due to adhesions from the previous surgery and so forth. We've done 9 patients now. Just briefly going through the yellows, you can see that renal function and glucose control remains about the same. Their hemoglobin A1C is improved, as you'd expect. The absorption of their immunosuppressive agents, which was important for us to know, is not really any different, and the dosing doesn't have to be changed. And they lose quite a bit of weight. They lose about 65% of their excess weight. But they do have more complications. We had almost 50% complications. Due to the adhesions, we had to convert one patient to an open approach. We had some mesh problems and leaks from the surface of the liver due to the scarring of the liver onto the stomach. But I think in select patients who are really obese and having problems with their liver transplant because of this, I think this is a viable potential approach. So we do have some data, I think, that shows that it's doable, it's safe, and it's effective in these patients. We do have limitations. We're the only center. I think there's a lot of interest around the country, but I have not really heard of any sort of program out there that's systematically implemented this. We did have low MELD scores at the start, although now we're becoming a little more aggressive since the patients are doing quite well, and our follow-up isn't really that long. But we can make some conclusions. As I mentioned, is pretty obvious, is that morbid obesity is a problem and does compromise liver transplant outcomes. What we do now medically is not effective, and the sleeve seems to be quite an effective approach in treating the obesity as well as providing better transplantation candidacy. So personally, I think that it is a potentially appropriate approach. We do obviously need more time and more patients to see what happens, and that is it. These are all the folks who have worked with me trying to get this program up and coming. Thank you.
Thank you very much. Maybe I asked the first question. I remember that some patients we send to you for bariatric surgery, you would like to see them losing a little bit of weight first before the surgery. Can you elaborate on that?
Yeah, so the question, well, you heard it. A lot of this is driven by insurance. I think insurance wants patients to lose weight to demonstrate that they have bought into the program, that they're committed to undergoing the procedure and all the other things that are associated with it. In terms of efficacy in terms of predicting efficacy afterwards, I personally don't think there's any data that shows that someone who loses more weight prior to the surgery is going to do better afterwards. And with these cirrhotic patients, I don't tell them they need to. I mean, I ask them to try to lose weight, but I don't make it a criterion.
So there's no set point or end point before you would operate, correct? No. Okay. Yes, Dr. Luba.
Yeah.
How often do you see people that you do bariatric?
I'm sorry, the question was how often have I seen resolution of liver disease after bariatric surgery? So it obviously depends on the etiology, but in patients with NASH, it's been documented that inflammation, steatosis goes down, and in fact fibrosis can resolve after bariatric surgery. So we've seen it in a couple of patients. We haven't really had a systematic follow-up with biopsies in these patients, but we have seen it in some patients, yeah. Yeah.
How do you deal with the alkaline reflux, and do you have any problems with aspiration?
In the patients with sleeves?
The sleeve.
Well, most of the patients actually have the reflux early on, and if you can bridge them through that with PPIs and so forth, and head up the bed, they do fine, and then it tends to resolve after that time. I think that if someone has really severe reflux, then we talk to them about maybe having another procedure done, maybe a gastric bypass.
By removing the side of the
Pylori?
acid-producing mass, you
Mm-hmm.
not only have alkaline reflux, the PPIs won't do anything for that.
You mean in the sleeve? Well, there is still mass there.
So,
I mean, there's still enough there to cause a problem, because you're leaving quite a bit of stomach in. So, yeah.
Mark.
Reconsideration for doing pyloroplasty.
Yeah, the question is whether to do pyloroplasty to reduce this reflux problem. Yes, that's been brought up. I hesitate to do that in someone with cirrhosis. I think, again, it's a problem in some patients, but it's not as common a problem as you'd think it would be, and most of the times it does resolve. The other option is to put a stent in afterwards into the pylorus, and leave that open for a while, and somehow it helps with the long-term outcomes. But I don't know if I'd want to do a pyloroplasty in a patient with cirrhosis.
Great. Okay.
Thank you.
Thank you very much, Andy.